my name is Eileen Davidson, also known as Chronic Eileen, and with me today for the Talk Over RA campaign for 2023 is Dr. Cheryl Barnabe, a Métis rheumatologist with a graduate degree in clinical epidemiology. Dr. Barnabe is an associate professor in the Departments of Medicine and Community Health Sciences, Cummings School of Medicine, University of Calgary. TalkOverRA is a campaign to help those with rheumatoid arthritis improve their communications with their rheumatologist around remission, but that is sometimes an unclear concept for many, myself included in the early years of my diagnosis. For the TalkOverRA campaign this year, I've decided to interview as many rheumatologists from around the world on what remission is. After attending the Canadian, American, and European scientific conferences, I really liked learning from experts in their fields from around the globe. I hope you learned something from this project and you can use in your journey with rheumatoid arthritis or even other types of inflammatory arthritis, wherever you are in the world. Dr. Barnabe is giving us the Canadian perspective on this topic. Now, don't forget to check out the other videos, especially the patient perspective video on what remission is to us. There will be a link and the description for that in the description of this video. Okay, so now we are going to dive in. First of all, thank you so much for joining me today for this discussion, Dr. Barnabe. Welcome, and I'm going to start off with asking you, what is remission, and is there a one-size-fits-all for remission?
Right. So when I approach a clinical visit, I try to use some objective markers of what remission would be. And so for us, that's really counting the joints, how many are tender, how many are swollen. And I think and then also there's things that we look at, such as how people indicate they're doing overall, and then how the physician thinks they're doing overall. And I believe that there's usually a discrepancy, and that's because we are taking just like the smallest snapshot and the smallest summary. We're not there constantly. But I also feel that sometimes that sort of global view of how someone is doing is also muddied off by like other things that are happening in life, or even if there's a joint that's still sore, it might be because of degeneration in the joint as opposed to that active inflammation. So I'm always trying to integrate those aspects when I'm assessing for remission as well. But if someone is telling me, I feel great and I have no flares since the last time I saw you, and I'm not tired, and I'm not stiff in the mornings, and I'm doing everything I want to do, like that's the optimal remission to me. So I think there's a few different definitions on how we perceive it.
That sounds dreamy to me. Now, you touched a little bit on this, but can you tell by blood work if somebody is in remission, and what are some of the important factors to look out for in our blood work?
I don't think the blood work always correlates well. And so there'll be people who have so many swollen joints and yet their inflammatory markers look normal. And then there'll be people who have a very high inflammatory marker because there's something else going on. They might have an infection. They may have an underlying cancer that we don't know about yet. So there's always reasons too that we will judge whether this seems to be fitting with a picture. I just would never rely on blood work alone.
That's really good to know. Now, when somebody does reach remission, how long does it typically last, and what can cause somebody to fall out of remission?
Okay. So I think that varies as well a little bit. Nothing's clear cut. If someone is doing really, like if I see them once a year, perhaps because everything is going really well, and they say, I have a few days where I felt a little bit stiffer, or I was a little bit more sore, or I wondered if I was about to flare, but then it settled down. I wouldn't get worried about that personally. I would say, okay, there's days where we all feel a little bit worse than other days, and there's other factors that might explain that. And people can go like that for years and years and years. There'll be other situations where those little flares, and not that they're little when you're experiencing them, but those episodes where things ramp up might be because there's been a recent infection, and maybe there's been like a few days of missed medications because people were unwell and they were told not to take their medications when they were sick. And so when you've had that little gap in the treatment protocol. That might be a reason. There might also be just that disease control is starting to become lost. And so the medication's just not working as well as it used to, or maybe we've tried to peel back some of the dosing and it's just necessary to be on full dosing. So I think those are some of the variables that can come into play. And then I think too, trying to understand what is driving those increased symptoms. It might be related to other stressors that are going on in life. And I don't think we have great data that says definitely your disease activity is related to the stress in your life. But I think there's probably a story there. We just haven't been smart enough to prove it or to put some science behind it to say that that's a real thing. But definitely when you're not sleeping well, when you're not, when you're worried about other things, it makes everything feel worse. So.
Absolutely. And if any researchers are listening, that is a great research topic. Can you still have pain, fatigue, or cognitive dysfunction and be in remission, and why?
I think that starts to get into that gray zone of what we consider to be the disease activity versus the consequences of the whole disease. So I would think that if the joint counts look great, there might be things that are tender, but there's nothing swollen, and we're still hearing about pain and fatigue. And I worry about the other things that are going on in life. And probably that's that mismatch between our biomedical approach to rheumatology versus considering the holistic aspect of the person. So one of the clinics I work in, we actually were tracking how people's joint counts were changing over 7 years. And I would always be recording, swelling 0, swelling 0, swelling 0, but there was still lots of pain, lots of fatigue, and people's function was declining as well. And so we went and asked people and said, what is going on? Like, I thought we were, I thought from my perspective, everything was going so well. And it was because we're so focused on the medications and we're so focused on the joint counts and get, all of those mechanical aspects of rheumatology that we weren't considering all the other aspects. So people still weren't sheltered appropriately, did not have access to all the food that they need. They're experiencing grief and loss in their communities, and all of those things were driving. And they said, you never asked me about those things. You never, you don't do anything to help those things. And some of those things I cannot necessarily help with, but I can put people in connection with those who can. And so once we took a broader look at people's lives and filled in some of those gaps and made some of those connections, people were doing better. So I think we are, we go in with a job as a rheumatologist and we forget about all the rest of the life that someone's trying to live.
That is so true. Personally living with rheumatoid arthritis, whenever I have stress or anxiety or something, my RA does worse, but it's not necessarily showing up in my blood work. So that's definitely something to make note of. What is going on in our life has a huge impact, not outside of just medications. Now, you sort of touched base on this again, but we all know that when you have rheumatoid arthritis, it's very often that you have other conditions coming along with it. So what comorbidities get in the way of someone achieving remission or lowest disease activity?
Oh, that's a great question. I guess there are things that happen over time with rheumatoid arthritis, and they're less common than they used to be. But somebody who goes on to have lung disease related to their rheumatoid arthritis, someone who maybe has had some gastrointestinal issues from some of the medications or some of those treatment side effects as well. Those are things that I would put more in that category of like damage or consequences of the disease that won't really change no matter what I do with the joint counts, right? So someone who has scarring in the lungs, that won't get better. And so it won't correlate with the joint activity that's going on. So that's one aspect of it. But I think that we know that, for example, depression is way more common in rheumatoid arthritis. It may be, we don't know the exact number. Is it 12% of people with rheumatoid arthritis have depression? Is it closer to 20? Depends how you sort of set what is depression and how you set the group of people that you're asking about that. But I think it's when you're having depression, it's also really hard to do all the other things to keep your disease well under control. So it's hard to get out of bed to go take a walk, or it's hard to eat the foods that will help nourish your body. And so all of those things will impact that disease activity down the road as well. So I wouldn't say that it gets in the way of it, but it certainly complicates managing things in that holistic way.
Definitely does. Thank you. And you also touched a little bit on this one already, but can you stop medication if you reach remission?
So that there are some people, yes, who can. I would say that we like to know, if you think of the immune system as sort of having a reset button, you might want to, once you achieve remission, I think it depends how early in your disease there's so many variables. I guess my mind is spinning of all the different variables into this. I think if you've got very early disease, you're able to get on treatment rapidly, things went really well, maybe that disease course is different than somebody who has had years and years and years of disease activity, and then you finally find the thing that works for you. You might want to stay on that and not even consider trying to come off of medications, because it's taken so hard to get to that point. Whereas if it was like a real easy beginning and things went really well right off the start, you may never need as much as someone who has had that long standing disease. So I think we feel more comfortable kind of letting things sit for a little while and just monitoring and seeing, are there any symptoms cropping up at all? Or, there's a bit of a gut feeling to things as well. So if you feel like someone's just right on the edge, they're doing okay, but, missing one dose will cause a flare, then I think those are different situations where you may or may not want to try to come off of medications. And I would never want to just stop cold turkey and see, can I go without it or not? I think it's better to try to slowly minimize doses or stretch out the frequency of doses, so that if things don't go well, that you can get right back into disease control capture, as opposed to having to then find a new agent and go and start the whole rigmarole again of trying to get things back under control. So there's a few variables in there, Eileen. Sorry, it's not easy.
It's not one size fits all when it comes to this. That's kind of the message I'm trying to get out there. So what you're saying makes a lot of sense to me. And, there are different types of rheumatoid arthritis. Somebody might be mild, moderate, severe. That is definitely an indicator of how their medication journey is going to go too. Okay, so a couple more questions. Here's one that people love. Does lifestyle play a role in reaching remission or higher quality of life with RA, including diet?
I would say yes. I would definitely say yes. There's definitely a link between exercise and well-being, and so that will translate over to your disease as well. So if you're able to get outside and enjoy nature, and that'll be good for your mental health, and then also the foods you eat. I know certain people will say that, oh, if I have lots of sugar, my joints flare up. Other people, it's different foods. I think that we should be trying to eat as healthy as possible. It's not 100% of the time. There's obviously times when you can't adhere to that, or you might have financial reasons that you can't afford all the best foods, or you don't grow your own garden or something like that, right? I think there's ways that we have to be flexible as well. But I think the more that we can help our minds fuel our bodies well, get the sleep we need, do the activities that we can do, those are all things that are just going to make you feel so much better generally, and then probably also with your disease as well.
Very true. Okay, so here's an interesting one, and I think you did touch base on this one a little bit already too. But are remission rates increasing, and why is this?
Yes. So if we look back, compared to the 20 plus years that it's since I started, things were so different back then. People did not have, like, we didn't have many options, and it was expected to develop joint disease, and, it was going to be this decline over time. And then, of course, that totally switched up with having medications we could use, and then more and more and more options as we went along in years. But I think we also got a lot smarter about treating early and being aggressive up front, and then seeing if we can peel back after things have gotten into a good state. So I think more and more, because we're applying those principles, we are seeing more people hit that remission. We just have way more opportunities to make changes, and that helps us get there. Saying that, I still have many people I see that it's still a struggle, and we've kind of tried every single class of drugs we can think of, and started rotating back on to biosimilars and stuff, where it's just really hard to get that immune system reset. So I glad that there's fewer people that are experiencing that type of journey, but yes, fortunately for most people, we are able to change that course for people who've been diagnosed in the last 20 years or so.
Yes, it's really exciting to see all the research and advances going on in rheumatology. My aunt was diagnosed with RA about 40 years prior to me, and she was in a wheelchair. I hardly ever saw her walk. She had the curled fingers, telltale rheumatoid arthritis. She passed away the same week that I was diagnosed about 8, 9 years ago. So I was really scared that that was going to happen to me. But now, being a patient part in research and all the advances and everything I'm learning about, we're not seeing that as often, and that's very exciting. Just as me, somebody living with a disease. Okay. Who has a higher chance of remission? Seropositive or seronegative?
The seronegative. And I think that's sometimes we wonder, do we actually have the diagnosis right? I mean, clearly there's something abnormal with the joints, but is there really, it wasn't really a reactive type of arthritis to some, infectious trigger? Do we have maybe, there'll be psoriasis that comes along down the road, and so it's really not the same as the seropositive disease. But certainly we expect people with those markers for rheumatoid arthritis to continue to have a tougher journey than those who don't. Some people think about it the other way, in that, maybe there are some symptoms they don't quite seem, consistent with rheumatoid arthritis. You're afraid to kind of make a call and say that it is rheumatoid arthritis, and then you don't have those usual markers, or people, when they go to their family physician, they'll do the blood work and say, oh, all of your markers are normal, you can't have rheumatoid arthritis. There's some misinformation about that seronegative group. And so then if you miss that early train to get things under control, then you are dealing with a more refractory disease maybe. So that's the flip side of being seronegative, is that it is not recognized early enough to make that early jump into treatment and then change the course over time.
Does it switch over to seropositive in that case?
No. So there's some people who just stay seronegative the whole way through. And yeah, so I think that argument goes both ways, actually, but generally we consider seropositive to be associated with more severe disease and more chance for some of those other complications, like the lung disease or the nodules that go along with rheumatoid.
Is remission more common in males or females? And is it more common in younger or older adults? Are there any groups of people who are more likely to not achieve remission?
So men would be more likely to go into remission. And that could just be the volume of women with rheumatoid arthritis driving that number as well. So that's a tricky one. When we look at predictors of remission, we see that there are a lot of prognostic factors that are present at the very beginning that may mean that you're less likely to achieve remission. So there are ties to some of those determinants of health. So it ties to how much education people have been able to attain, how much income their family household has. It might relate to how severe your disease was when it started. So if it kind of grumbles along slowly and you add a joint and add another joint versus someone who wakes up one morning and can't move and already has early damage that develops and such, I think that would be less likely to achieve remission. Just trying to think of what else. The age thing is a very interesting question. I don't actually know that answer, so I should look it up. But I that delay in diagnosis is a big factor. And so if people who are young all of a sudden can't move, they probably will go in and seek attention, and then hopefully that leads to the diagnosis and starting on treatment. But if you're older and maybe your rheumatoid arthritis is being confused with osteoarthritis or being confused with pseudo-gout or gout, or it's ascribed to some other thing, and you're older and you might expect, well, I'm going to get some joint pain over time. I wonder if that also might drive people not getting diagnosed early enough, and then they're less likely to get that remission in the long run. So long-winded answer to I don't know, but that's curious.
The other rheumatologist I've interviewed so far was stumped on the same question that you were. So I think that's an area for some more research.
Definitely.
All right. You've definitely touched on this one a bit, but I think it's one that we can dive into a little bit more. Early and effective treatment is important for those with RA. For many patients, it takes time to find the right medication or get a diagnosis. For those that it does take years to find the right medication or get a diagnosis, can we still reach remission?
We can. It might require more therapy. So it might mean that it's not just a single biologic or a single DMARD to get there. We might have to be putting more combinations together to get to that point. But I think it is still definitely possible. And luckily, again, we have such a long list of options that we can keep working through until we find one that works the best. So I would just, at that point too, I think it's less likely to ever be able to taper, to be honest. We might be able to minimize doses at some point, but just because it seems like then the immune system is kind of set in its ways, you've started to get some of the joint changes, maybe that lead to function difficulties. And so that global bigger view of remission is going to be much harder to get to for sure, but still possible.
Really good news to hear, because that's where I'm at.
Okay.
All right, so I only have one more question for you. You've done such a wonderful job answering these, and I've learned a few things from you, which I'm really excited about. What are some important questions patients can have with their rheumatologist around remission? And is there anything else you feel important for patients to know?
I would say definitely maybe when you are feeling like there's a disconnect on how you're feeling compared to what the rheumatologist is saying they think is happening, I would just be very brave and say, you know what, I don't agree with you, and these are the reasons why. Why are you saying I am doing fine? And then I think that would actually open up that rich conversation to talk about all of those other aspects of it. Because otherwise there won't be that window, right? It'll just be someone saying, I feel it this way and I feel this way, and there's a clash and people just don't resolve it. So then you're going to leave the visit feeling not satisfied because you don't feel heard. And so it's okay to question. It's okay to say, I don't agree with what your assessment is, and let's find a place where we both come to an understanding of where each other is at. That's what I would say. I would also, some people are very much like they don't want to even consider that medication tapering because it took so much to get to that point of remission. And you're also not wanting to take a step back. You don't want to go back to having to use the prednisone again, or cycle through a bunch of things, or it might just be, what, you're really, really happy to keep things exactly as they are, but yet we might be saying, oh, hey, I think you're doing so well, and you've been doing so well for so many years. And in our minds, we might be starting to think like, well, maybe there's been a lot of exposure to this particular agent. I don't want to run into troubles with some complication of it. So we might be trying to push a, let's peel back on doses. Let's start to try to taper. And if that's not comfortable for you, just say so and say, I'm happy with where things are at. And people say, oh yeah, you're right, I shouldn't want to rock the boat if someone's not ready. So that communication piece, we are not supposed to only just be telling you guys what to do all the time. We're actually here to work with you, and I hope that you have someone who's willing to work with you as well. The old days are gone. we are here to serve, and so I hope that those conversations can happen.
Absolutely. I think that having a conversation about how RA affects your entire life, it's so important to have with your rheumatologist. I look at them as our gatekeeper for specialists or other services that we can use, like social workers, occupational therapists, physiotherapists, all that we need to live a greater life with rheumatoid arthritis. And yeah, having that conversation and just asking your rheumatologist important questions. There is no dumb question that you can ask them. They're just so important to do. Well, Dr. Barnabe, thank you so much for joining me today and offering the Canadian perspective. Like I said, I've learned some things from you, and I know many others will as well. So thank you.
Really enjoyed being with you, Eileen, too. Thanks.